Good afternoon, everyone. I'm Beth Stewart, Director of the Texas Oral Health Coalition, and on behalf of the coalition and our conference partners, the Texas Health Institute and the Texas Department of State Health Services Oral Health Improvement Program, I'd like to thank you for joining us for the fourth installment of the 2020 Texas Oral Health Virtual Conference. I would like to now introduce Dr. Josephine Wolf, Conference Planning Committee member and the Oral Health Director for the Texas Health Institute, to serve as moderator and to introduce our presenters for today's session. Josephine, the mic is yours.
Hello, everyone, and thank you so much for joining us this afternoon. It is my pleasure to introduce our speaker, Candace Owens. Candace Owens is the Education Director for the National Network for Oral Health Access. She's a registered dental hygienist and holds a master's in public health and a master's in dental hygiene. With NNOHA, Candace develops educational resources for healthcare providers working in safety net settings, including webinars, in-person trainings and technical assistance, learning collaboratives, and various publications. Outside of NNOHA, Candace is a dental hygienist for a portable dental program in Denver and is a member of the Special Olympics Colorado Young Professional Board. Next, I'd like to introduce our three panel members, beginning with Kelly Cook. Kelly Cook is a licensed clinical social worker and the director of Genesis Prime Care Hope and Recovery Centers, and the owner of Hopeful Insights Consulting. She has practiced social work for 22 years in a variety of settings and has extensive training and experience in trauma recovery, behavioral health integration, and stress management. She collaborates with schools to provide trauma-sensitive and trauma-informed school trainings. She provides trauma-informed care and a unique form of emotional intelligence to hospitals, FQHCs, and medical practices. Next, we have Catherine Little. Dr. Little practices in a large federally qualified health center as a clinical pharmacist. She sees patients one-on-one or in co-visit models to manage patients' primary care disease states, such as diabetes, cardiovascular conditions, and anticoagulation. During the co-visit model, she serves as part of the multidisciplinary team, seeing the patients alongside primary care providers, specialists such as cardiologists and endocrinologists, dietitians, behavioral health workers, and/or case managers to provide a patient-centered medical home. Next, we have Yashashuri Urankar. Dr. Urankar is a dentist with over 20 years of experience in clinical and academic dentistry. She is the Chief Dental Officer at Community Health Centers of South Central Texas and FQHC. In 2019, the Oral Health Program received the John Rossetti Center for Excellence Award at the National Network of Oral Health Access Conference. Dr. Urankar started an initiative where she trained the primary care providers and staff on the Smiles for Life curriculum to increase awareness about oral health within the health center. She also collaborated with the Behavioral Health Department to discuss the importance of oral health in patients with behavioral health issues and needs. Continuing with the same initiative in the community, she coordinated an outreach team to visit with local ERs and was successful in establishing an ER diversion program. I'm very pleased to now turn this discussion over to Candace.
Hi, everyone. Thank you for joining us today, and thank you for having me. The presentation today will focus on integration of oral health and primary care practice. I'm going to start by presenting some content, and then I will lead into a panel with some great individuals who can share their integration work. So here are the objectives for today's session. We'll discuss successful oral health integration projects, describe the 4 systems needed to implement an oral health integration program, and explain how these Texas healthcare providers are implementing medical and dental integration within their organization. So I'm going to take a quick pause to talk about our organization, just to give some background on how we received data and information for this presentation. So NNOHA is the National Network for Oral Health Access. We are a membership organization founded in 1991 by a group of health center dental directors who identified a need for peer-to-peer networking, leadership, and support. Our membership now includes over 3,500 dental providers and partners. And pictured there is Dr. John McFarland, who helped found NNOHA. And this is before COVID times, obviously, with PPE and whatnot. But that's him working with his dental assistant there. So HRSA, or NNOHA, is a HRSA National Training and Technical Assistance Partner. We provide oral health training and technical assistance. We have a wide range of resources like learning collaboratives, webinars, and we also have a very active listserv, which is comprised of safety net dental providers. And we also have NOLI, which is our National Oral Health Learning Institute. This is an educational program for new dental directors, which we're accepting applications for this cohort right now. If that's something that you're interested in, that's on our website. All of our resources are available on our website, which is NNOHA.org. And if you have any specific questions about NNOHA, or if you'd like to look for a specific resource or have a question, you can always email us at info@NNOHA.org. So these are a couple upcoming webinars that we have that may be of interest to you all. On August 10th, we have a webinar on school-based dental programs and reopening. Then we also have another on burnout for dental leadership. So I'm going to now provide a little bit of background on medical integration. In 2011, the Institute of Medicine released this report. This report provided some recommendations for HRSA to develop oral health core clinical competencies for non-dental professionals. And it also provided recommendations for HRSA to increase the capacity of health center dental programs. In 2014, in response to that 2011 Institute of Medicine report, HRSA released this white paper called the Integration of Oral Health and Primary Care Practice Initiative. They developed a set of 5 core clinical competencies for primary care providers, and they also discussed the importance of translating these competencies into safety net settings like health centers. The goal of this initiative is to improve access to oral health by providing early detection of oral diseases and improved access to preventive interventions leading to improved oral health. NNOHA received funding from HRSA in 2015 to create this user's guide. We call it the IPOC guide. It's the user's guide for the implementation of the oral health core clinical competencies. We piloted with 3 health centers on implementing these competencies with their medical providers. So this guide discusses how those primary care providers at these health centers delivered oral health interventions. It also provides some recommendations for training your medical providers on oral health competencies, how to develop clinical protocols, and it also discusses some quality improvement measures that can be used whenever you have a medical and dental integration project. Now, moving on to the framework of this integration model. There are 5 core clinical competencies, and these competencies are intended for primary care providers to engage in. The first competency is risk assessment. So this is asking questions to determine the patient's risk for caries. Then the second competency is oral evaluation or oral health screening. So this is looking in the mouth to identify any abnormalities. Again, this is the primary care provider looking in the mouth. We're not asking them to diagnose, but to be able to recognize healthy versus unhealthy. The third is preventive interventions, which could include something like tobacco cessation, nutritional counseling, but more often than not, it's fluoride varnish. The fourth competency is communication education. So this is setting self-management goals and having discussions with the patient about oral health and how it relates to their overall health. And finally, interprofessional collaborative practice. This is the final competency, and this really refers to how the teams work together as well as bidirectional referrals. So again, the intention is that the primary care providers would complete these competencies during their medical visits. For example, they could complete a short oral health risk assessment during a well child visit, apply fluoride varnish during the pediatric visits as well. So just a couple of examples of how that would be implemented. Here are the primary care providers that can be involved in this model. I'll also mention that this is not just primary care providers who are active participants in integrating oral health and primary care practice. It really is the whole care team. So in other words, you can use your whole staff to be involved in this process. We've seen models where the medical assistant is able to apply the fluoride varnish or conduct the risk assessment, and also front office staff to help with that fifth competency of inputting referrals and whatnot. But these are some of the primary care providers that we've seen involved in this type of work. There are various ways that organizations can integrate, which you will hear from our panelists today. Here are some examples. Primary care providers can engage in these 5 competencies. They can also do behavioral health activities like depression screenings. Dental providers can screen for depression as well. They could do blood pressure tests, diabetes screenings, as well as screenings for HIV. Behavioral health providers can also screen for oral health conditions through risk assessment, and they also screen for other things like diabetes and obesity. These are some characteristics of a successful integration program, and so I'm going to dive a little deeper into each of these. Successful integration does not only mean that clinical practice is integrated, but the administrative culture is integrated as well. So for example, the organization should have regular meetings or retreats that include all disciplines. In addition, there should be leadership support for integration activities. All disciplines should have representation in committees and work groups of the organization. For example, a dental team member could be part of the quality committee. Additionally, there is also formal and informal communication that should take place across all of the disciplines. The clinical infrastructure is another integral piece for successful integration projects. Some examples include having electronic health records that include bilateral access. For example, being able to do shared appointment making or looking at each other's clinical note if appropriate. Policies and procedures that allow for bilateral referrals and tracking are also important as well. And finally, it's important that enabling services are available for all of the departments. Clinical practice integration is an obvious aspect for integration projects. We've discussed having different disciplines engage in other activities. In addition to what we've discussed earlier, we also suggest that there's interdisciplinary patient management for successful integration work. Finally, there should be an evaluation and quality system in place for successful integration. The dental and medical staff should be trained both in quality improvement initiatives such as the model for improvement. Again, having full representation from all disciplines on the quality improvement committee is important as well. We've found that organizations that have quality improvement measures that involve different disciplines like medical or like dental and behavioral health are successful in measuring their outcomes for integration. So some examples include sealant rates or depression screening rates as part of their quality improvement plan. Cross-disciplinary measures are also something that organizations could consider. An example of a cross-disciplinary quality improvement measure would be the number of patients in a dental clinic who've completed a medical visit, or the number of referrals from medical patients to the dental clinic. These are what we call the steps to success for integration. There are 5 steps or 4 systems that should be in place when creating an integration project. First is the planning phase. We don't call this one of the systems, it's just the first step. So this involves meeting as a group to plan your integration work. So when you're planning, you want to consider who is going to be part of your team for this integration project. And the really critical element is that all disciplines that are involved should have representation on the integration team. So if you're doing a medical and dental integration program, there should be a medical champion and a dental champion. We also encourage having someone from the operations or IT side to help make workflow changes or any changes that you may need to your electronic dental or medical record. Then we're led into the actual 4 systems. So the first one is training your providers on that new discipline. So if you're going to, for example, have your primary care providers engage in oral health activities like the competencies, you would have the oral health providers talk to the primary care providers about oral health, and they would learn about the oral health activities that they're about to engage in. Health IT, this is using your electronic dental record and electronic medical record for documentation and tracking of these integration activities. If you, for example, are applying fluoride varnish, how are you going to track that within the electronic medical record if applied during a medical visit? Clinical care is a third system, and this is workflow. So how does the appointment flow now that a provider is participating in this new activity? For example, if they're going to be doing oral screenings during the medical visit, at what point of the appointment are they going to be doing these screenings, and how does that change the workflow for the provider? And finally, evaluation systems. This is to determine that the program is successful. And so again, this goes into what we talked about just a minute ago. What outcome measures will you evaluate to help determine the success, and how will you get that data? So now I'm going to transition to our panel discussion, which includes the 3 individuals that Josephine introduced earlier. So we have Kelly Cook, Dr. Catherine Linton, and Dr. Yashashri Urankar. So if we could go ahead and transition to the panel, and if we could go one by one and have you all introduce yourselves and talk a little bit about your integration work. We can start with Dr. Urankar if you're ready.
Yes, thank you, Candice. And that was a lovely presentation. I've picked up some things that probably we can incorporate in our practice too. That's wonderful. This is Dr. Yashashri Urankar, and I am the Chief Dental Officer at Community Health Centers of South Central Texas, which is a federally qualified health center. We have 8 clinical locations, with 7 of them having the dental program. And we span across 5 counties in the south central part of Texas. And as an introduction, I would like to just say that federally qualified health centers, or any community health clinics for that matter, are very uniquely placed in our healthcare system, where we can leverage this concept of interprofessional education and collaborative practices, and it can actually have impact on our communities. So like most of the FQHCs, our federally qualified health center also provides services like behavioral health, primary care, dental care, women's health, pediatric practice, OBGYN services, and all these are available under one roof. Now, we started our integration project as a pilot project in end of 2017, early 2018, and we picked up one of our clinic to start this project. So here we basically begun, as we go into the discussion, I will give you all more details, but we basically begun by involving all the team members, giving them the oral health core competency training. I used the Smiles for Life curriculum for training them. They had a lot of questions. It was great. And basically in these FQHCs or any health centers, the dental clinics generally work at a capacity that is 25 to 30% of the medical clinics. So we had to prioritize our population. So we prioritized our population by segregating them into target groups like pediatric patients, pregnant women, patients with comorbidities, patients with diabetes, and henceforth. So this is a brief introduction of how we brought about the initial steps of our integration. Thank you.
Thank you. How about Dr. Litton?
Hi, thank you all for having me here today. I am a clinical assistant professor at the University of Texas College of Pharmacy at Austin with a practice site at Community Care Health Centers, which is a federally qualified health center in south of Austin. My clinic that I work at is very similar to the one that Dr. Urankar was describing, where we have many different pieces of the care model under the same roof. We have primary care with internal medicine and family medicine. We have behavioral health, social workers, OBGYN, pretty much anything you can think of, as well as a dental clinic at my clinic. However, we have pharmacists that work at many different clinics across the city that don't have dental clinics. The clinical pharmacist team, as was mentioned in the introduction, we mainly manage chronic disease states under a collaborative practice agreement. So we are able to write prescriptions, refill, order labs, and analyze labs. And we do see patients individually as well as a part of the care team. But one of our main duties outside of chronic disease states such as diabetes, heart disease, that type of thing, is anticoagulation. So we manage all of the anticoagulation patients in the clinic system, which is over 550 patients, and a couple hundred of those are on warfarin. So we need to monitor their INR, and when a patient has a procedure coming up, such as a dental procedure, we need to ensure that their INR is at goal. So we have created a system to be able to communicate that the patient had a recent INR within 72 hours to the dental clinic so that they're able to safely proceed with their procedure. And we also work with them to create protocols for their aminocaproic acid and dental. The pharmacists run the medication safety committee for our federally qualified health centers. So dental is involved in that as well.
Great, thank you. And Kelly?
Yes, and again, me also, we have the same thing. We were FQHC, so we have lots of services underneath the same banner. Ours are a little different. We actually have a trauma specialty program, and so we are undergoing a certification with TAC right now to become an organization that's trauma-informed certified. And so part of what we looked at as an organization as we're undergoing trauma-informed care was to have every part of our organization to be trauma sensitive and trauma informed. And so, of course, we looked at our dental practice because we know how triggering it is for patients that have anxiety or previous trauma to come into a dental appointment. And in fact, as we started assessing it, we started realizing that a lot of the patients were actually leaving before they were receiving the services. So that made us passionate about to begin to start in our dental clinics to really start to provide training for our staff and to provide screening and the connectedness of the integration that we have in every other area we were lacking in dental. And we realized that that was actually more traumatizing for patients than primary care. So we started doing training and providing screening and integration, and even having behavioral health workers come into dental and meet with the patients right there to provide coping and support. So.
Great, thank you. So to get us started, let's talk a little bit about how you trained your non-dental team members and providers on your integration project. And so I'll start with Dr. Urankar because you did mention that you utilize the Smiles for Life curriculum, but if you could talk a little bit more in depth about how you completed the training, what did you do to ensure sustainability for any new team members that join, and why you selected the specific curriculum that you did?
Okay, let me start by saying that I was researching different models of integration to see which one best fits our organization as looking at our demographics and the kind of providers we had. And when I was researching, in one of my resources, I came across this Smiles for Life curriculum, and I did it myself. I went ahead and I registered. It's an online program, and I saw that this particular curriculum, it interested me because it has 9 modules. It has been gradually developed from, I believe, 2001 or 2002, and it encompasses the entire spectrum, right from the front desk training to the medical team training and to the outreach training. And it gives a brief and a good perspective of how oral health and systemic health correlate with each other at different levels: pediatrics, adults, pregnant women, in teenage, in geriatric. So that model really interested me, and that is why I used that model. And after utilizing it with my care teams, which consisted of a pediatrician, OBGYN, a family nurse practitioner, and they are medical staff, the MAs, I also included my front desk staff along when we had these trainings. And it really gave me a good feel that they really understood. The language used is simple, and it's directed towards the medical care team, the language. So it made it easy for them to understand. And that was the reason I selected. And basically after that, what we did was we actually developed risk assessment forms. Like Candice had explained, we had risk assessment forms. We added a few oral health questions to the comprehensive medical history side of the EMR, where then the medical provider would actually be directed to ask those oral health questions. We placed education material, patient education material in the medical clinic so that the MAs could distribute the literature accordingly. And that is how we went about it.
And how about Dr. Lynn?
For the beginning, I wasn't involved in the very beginning of this protocol because it's been around for quite some time. But when I came in, I didn't have any specific training about the protocol other than the protocol itself. It is based on the guidelines as far as what the INR goals are, and clinical pharmacists will be familiar with those guidelines. But as far as the workflow in place, that one was trained to me when I came on as a new pharmacist at the clinic.
Thanks. And Kelly?
So the training, we don't have a specific training that's a curriculum. I have trauma training of about 20 years. And so I wrote something for our center because I felt like they needed something specific. And so the training is basically just an awareness of trauma. It's awareness of how trauma impacts patients, how trauma impacts health, how patients are not actually coming to behavioral health services, they're coming to primary care, they're coming to dental, and being able to have a sensitivity and awareness of what triggers patients. Also, we spent a lot of time in the training looking at the dental practice and we were lucky enough they were remodeling. And so we were able to sit down and actually talk about what do we need to add into the dental practice to make it a more sensitive practice, help patients to be more settled and relaxed in the setting. And then we did a form of emotional intelligence, which just helps people to be aware of their own triggers and their own reactions and to be able to have more empathetic responses available. And then we worked together actually as a team to develop the referral process and how we would do things. So it was actually something that got developed out of our passion for integration.
Excellent, thank you. And so as far as your clinical workflow process, explain that a little bit for your integration activities. What are the roles of the dental and non-dental team members? And do you leverage your health IT system at all for documentation and referrals? And we can start with Dr. Urankur again.
Yes, we definitely do that. The first step in the process now, just for example's sake, let me start by talking about patients that have chronic diabetes. Now, if you use this patient as an example, after the first step is, of course, share the education piece. Once the education piece was in place, and adding the health questionnaires to the comprehensive health exam, as I stated before, what happens next is once you have a new patient come in, once the diagnosis of diabetes has been established, the primary care physician and her team, the MA, they provide education about the correlation between diabetes and oral health and why oral health is important. They provide them with education material and try to insist that they make an appointment with the dentist, and so that they get the best benefit of the whole process. But and then we have a checkout card where a follow-up card that goes with the patient out to the front desk, where we have added the follow-up with the dentist tab, which is checked off, and then this patient goes in the front, which prompts the front desk to make that dental appointment for so that the patient can follow up with the dentist. And we do track this through our system, in the sense we have created reason codes where we have integrated appointments at for different types of patients. And then to close out that encounter, the reason code is used as MDI, which is just simple like medical dental integration. That's why we kept it MDI. And then through our electronic health system, the provider also tasks the dentist, just allowing them to know that this is a patient which you should expect to come for oral health needs. So that's how we track. And we use IT to develop these tracking codes, run reports to find out how many of these patients who are actually have been assigned these codes have come and actually made those appointments. And that's how we get our percentages of compliance from the patient. And on the dental side, when the patient comes, of course, we have our comprehensive part of the health history, but specifically with diabetes patients, after reviewing their medications, we focus on the hemoglobin A1C. We track the hemoglobin A1C before starting dental care and after finishing hygiene, because there is a lot of evidence that states that after getting a thorough scaling and root planing, the hemoglobin A1C does improve at least by 0.29 or 0.5%, and that it's a bidirectional approach, because glycemic control helps, causes the oral health problems, and if you have a good oral hygiene, it controls the glycemic index. So because of, so these are the, and we can actually show the patients also how they are improving. So that's how we focus on diabetes and how we handle diabetic patients.
Thank you. And how about Dr. Litton?
Sure. So at every anticoagulation clinic, we kind of have a list of general questions that we run down so that we're able to make any adjustments that we need to, or really analyze that INR lab, of course. But some of the questions that we ask are preventative. So are you planning to have any surgeries or procedures coming up? Do you have a dental appointment planned? And what is the plan for that dental appointment? Because a lot of times when we say dental procedure, or when we say, are you having any surgeries or procedures coming up, they don't think about dental, teeth removal. So we have to specifically ask about dental procedures in each clinic visit for these patients. After that, we determine the risk of the procedure. So is it a high bleed risk procedure? They're getting multiple teeth taken out, or is it a low bleed risk procedure? Are they only getting one tooth taken out, or are they only doing a small incision? Following that, we will make sure that we schedule them an appointment to come back and get their INR checked within 72 hours before that clinic visit or the dental visit, which is really easy and nice if you're at one of the two major FQHC clinics that we have that are in our system, because they have dental clinics on site. But at some of the smaller clinics, they will have to go to a different clinic to get their INR and their dentist, based on what pharmacist treats them. Following that, we give them a little card each time that says, this is my INR today, this is my warfarin plan, when am I following up, as well as the pharmacist's phone number, and they bring that card to their dental appointment so that the dentist is well aware of what their INR is. If it's too high, then they can, make the decision to either defer the procedure or go ahead with it based on their risk for bleeding. Some of the other projects that we do with them just kind of pop up. For example, I mentioned dental is sometimes invited to our medication safety committee. One project that we recently implemented is we don't normally have, after they go to the dentist, they don't get a patient plan like they would at the doctor's office that would say, you're starting on this medication, stop this medication, follow up with these people. So we actually created a really easy kind of check mark patient plan that the dentist can fill out that has all of the usual medications that a patient would be on, such as amoxicillin. They could just check, you're starting amoxicillin, and here's the instructions for that. And we were able to get those printed in English and Spanish, which is really helpful for our patient population. So they get invited to these projects and help allow us to improve the workflow and improve our patient care.
Great, thank you so much. And Kelly?
We have a screening process in place where any patient that comes in, a dental patient, receives a generalized anxiety screening. They also receive the PHQ-9 depression screening, and also another little screening that we created that talks to about previous dental trauma that they may have experienced, or how anxious are they today about their visit. So we actually try to screen their level of anxiety in the moment, and then what would make them more comfortable, and then or are they receiving behavioral health services? So they really have a good window of opportunity to see what's going on with the patient. And I guess most of you are familiar with PHQ-9. If not, there's a question on there that talks about, are you having thoughts of harming yourself or someone else? And we've actually had several occasions where they have circled yes. And we've been able to use the integrated care worker to come and talk with that patient and navigate immediate services. Some was emergency, another was we were able to just get a behavioral health appointment that day, which that would have been completely missed had we not been screening. And so when the patient finished the screening, the front desk staff actually reviews it really quickly and gives it to the assistant or the hygienist. She or he looks over it and then makes a determination the level of need. If it's not an immediate need, they may wait till after the services. But if it's an immediate need, we get the integrated care worker to come in, do some coping with the patient, and then complete the visit. And then she sets up behavioral health services for the future if the patient is open and willing to do that. She does that through making a phone call, using a referral form. Unfortunately, our EMRs right now, our EHRs are separate, but we are working on an integration process to actually use the same EHR. So that's going to actually help us a lot.
Thank you. And Kelly, just to follow up on that, the PHQ-9, when they complete it, is that documented electronically at all?
Yeah, so it is scanned. So two things happen with it. It gets scanned into the dental EMR, and then it comes down to behavioral health, and it's scanned in both places. Yes.
Okay, got it. Great, thank you. And so what outcome measures do you all evaluate in order to measure the success of your integration activities? And how are you at now when you look at your outcome measures? Dr. Runker, do you want to start?
Yes, definitely. Now the outcome measures, first we on the operational side, we would like to know how many of those that were referred for dental care actually keep the appointment and come for the dental appointment. So we could follow up with the rest of them who do not. So that tracking process is done through the code that we have created. It's an administrative code. It's a non-billable code. And we have that reason code as MDI, as I mentioned. So that is one that we use for seeing. So we sometimes we don't have as much a success as we want to. It's just because of the lack of dental insurance. Medicare covers the diabetic visits, but then they do not have any dental component to it. So and then of course then we try to have the patients come to us, and then we try to put them on our sliding fee scale. and try and give them those appointment dental visits as needed. That is one aspect. Second, as I already mentioned, in diabetics, we generally would track the hemoglobin A1C to compare before and after. That is one tracking process we use. And also I think we use the same MDI code for tracking the no-show, as I already mentioned. And based on the care they do, even on the medical side, besides diabetic patients, we talk, they also talk to pediatric patients and other patients who need dental care. So they are logging caries risk assessments. So we follow that, we follow those caries risk assessment codes and try to see whether the patient's caries risk assessment has gone down in the follow-up visits. So that's basically how we use our system.
Thank you. Dr. Linton?
To be honest, we haven't really measured any outcomes specifically related to the anticoagulation. Just anecdotally, I've never had a patient be turned away from their, health there, or be unable to do their dental procedure unless their INR was too high. Every time we've pretty much caught it and been able to check their INR or reschedule them in the next week to get their procedure done once their INR was at goal. So it would be certainly an interesting thing to measure, just to make sure that we are getting our patients into and meeting their dental outcomes on time, and they're not being delayed due to out of range INR. But I would say most of the time, in my experience, that we have been working very well together.
Great, thank you. And Kelly?
So we're under operation of about 60 days. Obviously, COVID has slowed down our process, but one of our goals was to improve patient satisfaction, basically by us being more sensitive and helping them to have a better dental experience. So that's one of our goals, is to look at our patient satisfaction over time and see, are we really providing a more sensitive environment for patients? Are they feeling more comfortable being in the dental experience? But also, obviously, increasing behavioral health referrals. So we're going to track that through our referral system, and we're looking at about 90 days. We know that we've had an increase. We've had, at least in the last 60 days since implementation, we've had 30 referrals from behavioral health, where we had probably one a year. So we know that we're increasing the referrals. So we want to increase referrals as well as increase sensitivity and improve patient experience. That's our first year project goal. And I think we're right on target for meeting some of those goals that we have.
Great, thanks. So we're going to start to close up a little bit here, but just a couple of minutes for each of you to share maybe one challenge and one positive for your project. How about you, Dr. Yarenker?
Let me start with the challenge. The challenges are the consistency, to maintain the consistency in training, to maintain the consistency in retraining. We do have staff turnover. So sometimes that lags behind, and we face major challenges in that area. And in the successes, we do have patient satisfaction surveys where the patients are happy with the kind of care we are providing them. And actually, the feedback that I got from the medical providers in our clinic are that they really appreciated the educational component, where they could really get a deeper insight into oral health and how it affects systemic health. And that has changed their perception and the way they handle patients.
Great, thank you. Dr. Linton?
I think some of the challenges would mainly for mine be like if a patient doesn't come to their INR appointment within that 72 hours, like we get a no-show and then they go and show up at their dental appointment. What do we do then? Is it safe to get their dental work done, or do they need to get that checked and turn them away? So I think some of the challenges are just making sure our patients understand the protocol and why it's so important for them to get that INR checked and follow up prior to their dental procedure, and then pretty swiftly get it checked again to make sure there will be no negative outcomes. So that's probably the main one, is making sure to educate patients.
I think the challenge is always probably for across the nation for behavioral health is just not having the immediate availability. I mean, we have a robust behavioral health program in all of our locations, but just not having that integrated care worker. She may be with a crisis, all the other therapists may be in session and not be able to get out to do that immediate care when needed. Because we know that when we do the integrated care and the therapist or the social worker is able to meet that need right there, then we have a higher chance of success that they will actually continue behavioral health services if they actually meet one of our providers. But one of the benefits was the dental team was amazing. They were open, they were excited in the whole training. They transformed the whole dental practice, honestly, to be more sensitive, and they've been passionate about it ever since. So it's been a pleasure to work with them and see what they've taken and done on their own, even after the training.
Great, thank you. Well, thank you three so much for being part of this panel and for sharing information about your integration work. It's really inspiring to see you all working collaboratively for the sake of your patients. I'm now going to pass it over to Josephine to lead our Q&A.
Great presentation, everyone, and thank you so much for coordinating, Candace. So I have a quick question for the panelists. Looking at the number of attendees that we have, looks like we have some folks inside of dentistry, some outside of dentistry, and some in different roles within each of those. So if you had the chance to offer the first step to, say, a provider in a dental office, whether it be the dentist, the dental hygienist, or a support staff, and they have identified their patients consistently have a health issue, and they want to connect and coordinate care with the provider, what would each of you suggest that very first step be that can be taken, whether that's in a standalone clinic, an FQHC that does not have support services along with it, or a private practice, or an FQHC that does have other clinics within it. So let's start with Dr. Urenker.
Yeah, I think the first step would be to evaluate the patient's medical history in detail. And as a dentist, I would definitely try to consult with the patient's primary care physician or any specialist that the patient might be seeing to see what could be the barriers that are preventing the kind of outcomes that we are trying to look into. And together that is a start of integration, just talking to the provider, trying to keep patient as a center of focus and working from there.
Thank you. Yes, that's an excellent recommendation. Dr. Litton.
I have to echo that as well. Just reaching out to the patient's primary care doctor is probably the best step, and then that person will know where to go from there. I think especially I think all three of us work in FQHCs, and we're very well aware that a patient's medical outcomes are not just dependent on their medical status, or it's completely dependent on outside barriers, social factors, their access to care. So I think you hit it on the head, like identifying what those barriers are and who we can connect them to within the extended care team to try to overcome those barriers is one of the best things that we can do to patients.
And
Yes,
Kelly, I'm sorry. I was just going to say, if you could speak to that, but also through the lens of trauma-informed care.
Yeah, so I think the first step, obviously, for me was just educating. So collaborating, educating, because they are not aware sometimes of the depth of what the patients are struggling with. In FQHC, it's much easier probably because we are aware, we are dealing with the underserved. But from a trauma-informed approach, sometimes it's necessary to do just a little gentle education about what patients might be bringing in and what might be the struggles and the barriers. I agree the same. And just coming as a collaborative effort, because we can't do this by ourselves. We all have to work together because the patients are complex and difficult. And we're living in a world where we need to be trauma-informed because we are all going through something really horrific, and we need to be sensitive and well aware, but we also need to take really good care of ourselves as well.
Yes, very, very good. So what I heard there was kind of some of the first steps are just reaching out to that other provider that cares for the patient, and then also being aware that not everything that affects that patient happens in a dental or a medical office, that there are factors outside of a healthcare setting that affect the health of our patients. And then that last step is education, making sure that we are educating firstly ourselves. So we're doing that. So we're taking the first step by being here today, and also our patients and the other providers that we work with. Yes, thank you. So Beth, do we have time for one more question, or do we need to go ahead and wrap things up?
Well, I think we have time for one more question.
Okay. So being that we have no questions in the Q&A, I am going to ask a question myself. So many of you mentioned that you had forms and tools that you either developed yourself or that you have kind of through your own research identified. Is there any one particular form or tool, website or resource that you recommend to our group of attendees today if they want to begin this care coordination within their practices? And Candace, you are welcome as the expert to comment on this particular piece as well.
Sure. Well, I'll chime in from NOAA's perspective. We talked and heard a little bit from Dr. Urenker about the Smiles for Life curriculum. I think that's always a great starting point if you're looking to engage medical providers in oral health activities. Free online training there. We also have our user's guide, our IPOC guide that I mentioned, that outlines those core clinical competencies. And so that's a good baseline to start, just to get some ideas on where you can start integrating. And a lot of those things, even though we're talking about primary care practice in that document, can be applied across disciplines, whether that's behavioral health and etc. Those are all the same framework that you can use for other integration projects.
Does anyone else have anything to add?
So I think the Texas Association of Community Health Centers, if you are an organization that is wanting to move more towards trauma-informed care, they have a certification program. I also do a lot of trainings to health centers and a lot of trainings to the community on trauma-informed care, but definitely reaching out. SAMHSA has great integration and trauma-informed care on their website. Just get started, because there's a lot of wealth of information out there. If you're passionate about that, there's a lot that you can do to transform your organization to be more sensitive.
Yeah, thank you. Thank you so much for that. We really appreciate the time that each of you have taken today, and the time that all of our attendees have taken to attend our panel discussion today. We know that in order for us to move the needle on improving the quality of lives of our patients, we need to work together within disciplines and coordinate that care. Thank you so much again, and I now turn this over to Beth Stewart.
Well, thank you, Candace, and panel participants, for such an informative discussion. And thank you, Dr. Wolf, for serving as moderator for this presentation. So thank you all again. Thank you, presenters, and thank you, audience, for joining us today. Have a pleasant afternoon, everyone.